Um, good afternoon and evening, everyone, and good morning to those in the eastern part of the world. We've got Ashish Patel with me today and Mike Selby hosting for the virtual Global Spine Conference. Ashish is an amazing spine surgeon who is the chairman of spine surgery at Julie Health and Care, Chicago, Illinois, in the US. And he is joining me today to discuss prone lateral from degenerative to deformity tips and tricks. And I think this is a super important topic. We've got a range of cases and other things to discuss. I found this a really valuable thing, and I will admit that I copied Ashish. I saw him doing this online during the pandemic, and you know how we like to go and do visitations as surgeons and learn new things, but really COVID killed that for a couple of years, right? And so I saw Ashish and John Ashka doing prone lateral. I thought, geez, I've done a lot of lateral. I'm going to do this myself, and so was able to take that on, and it's gone pretty well so far. But it's basically, to me, a demonstration of how you can learn online if you've done a few things yourself in the past, and you can just add to your skills. But Ashish has done probably hundreds more cases than I have, and I think it's going to be very valuable to hear his experience. So, as always, today it's an interactive session. We've got a few of the faculty online with me, can jump in and ask questions. But if you've got questions, put them in the chat box, and I'll put them into Ashish when we can within the presentation. So I'll let him talk, and thanks for coming on board, Ashish. Great to have you with us.
Mike, thank you. And want to thank Virtual Spine Committee, Mike Selby, for the invitation to allow us to present our work. And so you see the screen? Let me share my screen then. Can you see that, Mike?
We got you.
All right, great. All right, so today I'm going to be talking about something that I'm super passionate about. It's, prone lateral surgery. And I'll be talking through my learning curve and my journey from performing and trying to perform prone lateral from a degenerative perspective all the way to getting comfortable and performing it in deformity surgery as well. And I'd like to thank my research fellow, Michael McDermott, as well for putting this talk together. So I'm going to start with a case. It's a case of a 48-year-old female. She presents to the office with chronic low back pain. And you can see from the picture there, she has this inability to stand upright. And these are the pictures of her back in 2017. You can see that she has this degenerative disc disease from L3 through S1 with a spondylolisthesis at L5, S1, and a very high pelvic incidence of 95 degrees. So she obtained a L3 through S1 fusion, and subsequently didn't really do that well. By the time she presents to us, it's been 4 years out. She went on to fuse those inner bodies. They were 3-level TLIF. She has hyperlordosis at L2-3. And because of the continued chronic low back pain, she also had somebody put a spinal cord stimulator as well. Here are standing films. You can see that SVA around 15 degrees. And what's interesting is that she has an almost vertical sacral slope now with a pelvic incidence of 103. So she wants something done. She's failed conservative treatment. She knows she's young. She doesn't want to live the rest of her life in this position. So what are we doing? Where are you stopping? What's your upper instrumented vertebra? Are you performing osteotomies, inner bodies, maybe a second spinal cord stimulator, or something other, or a combination of these things? Mike, taking a look at this case, what are your thoughts here?
This is a challenging case, right? And I think in these bad sort of mechanical issues, spinal cord stimulator, probably relatively low harm, but if it is put in through a laminectomy, sometimes that interferes with your upper instrumented vertebra level as well. If you're sort of thinking about stopping around T9, T10 for these deformity patients. I mean, this is a relatively young patient. Just thinking they've got reasonable bone quality because despite the mechanical stresses, they fused that first operation. So bone quality is probably going to be okay. Looking at sort of habitus, not the smallest patient out there, so there will be a bit of stress on the instrumentation. And when I look at your full length sagittal film, she's doing a bit of that sort of water skiing kind of thing. So her alignment SVA may actually be worse than what you're seeing there. She's holding herself up on the X-ray. So we're dealing with a fairly substantial problem here. And look, I mean, I would definitely be looking at some sort of osteotomy, probably combined with interbodies going up and trying very hard because the disc at 1-2 seem to be okay. So maybe not taking this all the way up if I can get excellent alignment through what's been done via an osteotomy, pelvic fixation, and maybe an interbody at 2-3, a nice, really lordotic one, because those are all fused. And so it's going to be hard to get this back now. And maybe we have to actually change the patient's PI here to try to get this right. That's just my thoughts.
Yeah, definitely an interesting case that doesn't present to the office very frequently, thankfully.
No.
But
it's vertical sacrum. It's like a neuromuscular scoliosis down there with that, the sacrum just like that. So yeah, I just have a look at the chat box, see if anyone else has got clever ideas. So no one's put their solution forward for this quite complicated issue yet. So you're going to show us the solution a bit later, is that right?
Yeah, that's right. I mean, if you look at this, and it was something I post on LinkedIn. Another great thing on LinkedIn is that you can post difficult cases like this and see what sort of approaches that people would use, and sometimes there's a bit of a consensus here. Like if you look at the PILO, it's not terrible. It's 14.5 and not so off, but if you start to place inner bodies, hyperlordotic inner bodies above, I mean, you're chasing a very, very high PI, and it's hard to know how that would turn out and where you got to stop. But there was some consensus around performing a distal osteotomy in this case, and this is something that I'm going to continue with a little bit later. And so getting back to the talk, my disclosures are here, and the one that's relevant to this would be that I'm part of the product development team with Invasive to refine their prone lateral solution. And this journey really starts, with my training. I trained fellowship at special surgery, and there I was, like, majority of my cases were open posterior base surgery, both degenerative and deformity, and lateral surgery representing maybe 5% of my case mix. So I had, decent exposure to it. And when I think about the way my practice has unfolded in the last 8 years, I've gravitated more towards trying to obtain an outcome using minimally invasive solutions. I feel like that's more conducive to the patient population that I see and the people that come to my office. I probably treat around 75% of degenerative surgery, single or double level, primary virgin cases, but 25% of my case mix is going to be revision surgery, deformity surgery. And what I'm seeing in the office is a pretty healthy, active, older population. In fact, the data suggests that there's going to be a doubling of patients over 65 in the next 10 years. And everybody wants to play pickleball. So they're coming into the office with a back problem, and you've got to kind of find the right solution that fits that patient. And hopefully It's a minimally invasive solution and an efficient solution. And times are truly changing. We've got this rapidly growing active population greater than 65 with bone health issues, sarcopenia, comorbidities. We've got cost constraints from the payers and the hospital systems to reduce cost. And then we've got a movement to perform single and double level degenerative surgery, including lumbar fusions, from the hospital setting to the ambulatory surgery setting. So we're asked to do more with less. And so there's this real need for surgical efficiency. And we know the benefits of anterior lateral interbody, both lateral and ALIF, in perioperative parameters when we look at blood loss, hospital stay, time to walk in over traditional posterior interbody surgery. And the advent of single position surgery, which is performing ALIF and lateral in single position, where we can avoid performing the intraoperative flip, really has allowed us to start to think through this problem and create efficiencies around already well-established great surgeries and refining them to be even better. And I perform single position lateral surgery. I think it's an elegant solution when we're thinking about L5-S1 or L4 through S1 in a virgin case. But there are often times in my patients where I need to revise hardware, perform osteotomies, decompressions, and place pedicle screws in a multi-level construct. And so for me, the ideal position to perform that in is the prone position. There's some added benefits to the prone position. With hip extension and knee extension, you have gravity, which creates passive lordosis, especially through the segments at L4 through S1 where you need it. And so we started by constructing a crude apparatus where we use orthopedic bolsters and tape. And what we're really trying to do is recreate the contralateral bolstering effect of the table that we don't have anymore. You can see it's traditional prone position, and the orthopedic bolsters on the contralateral side provides us a little bit of resistance. And so the full technique is beyond the scope of what we're going to talk about today, but I have my technique on YouTube. You can use this QR code to scan and take you to that page. And so the journey starts in 2019, and here I want to tell the story through this graph here. It's retractor time on the y-axis and the case number on the x-axis. And we published our results, the learning curve, in 2023 in European Spine Journal. And when we first started, position is pretty relatively intuitive, but there was a lot of nuance about, do I sit? Do I stand? Where's the surgical tech? Where do I place the articulating arm? What am I seeing? How do I stay safe? And you can see the retractor times when we first started were really pretty high. And one of the things when you're in the prone position is that you are faced with a little extra retroperitoneal fat that creeps into the working corridor, within the retractor. And this could be whether you're using a 2-blade retractor, a 3-blade retractor, or a 4-blade retractor. And this is not unique to prone position. It happens in lateral too, but I would just see extra fat creep in the prone position. Here's a case of a 57-year-old female. She's got an L4-5 spondylolisthesis and a BMI of 38. And when we were faced with the retroperitoneal fat creep, I would take a pituitary and either try to sweep it away. And this one time I kind of picked at it and created a perforation in the peritoneum where I would have the beginnings of bowel that came into my retractor space. And that's a scary thing to see. I'm thankful that there was no bowel injury there, but it definitely taught me a lesson that I cannot move or pick that fat. And so we developed a method in which we would place the cut fingers of a number 9 glove over the retractor blades, like you see on this video. And what that allowed us to do as we placed the retractor within the retroperitoneum and expanded the retractor is that we would create a safe working corridor that would minimize the fat creep from coming into visualization. And this is something that we interacted with, right, Mike? Something that I think a few people found pretty useful, and they integrated into their workflow.
Yeah, Shish, I love this technique. I think it was because I had the same issue with you. I mean, I've never didn't see bowel during this, but certainly seen some bowel during laterals previously, particularly with scarred retroperitoneum. I mean, the peritoneum itself is a very thin structure, right? And it does reform, and it's more about recognizing when you're through it, I think, than being too worried about it. But obviously, if you get bowel then coming into your field, it's a huge issue. So I love this technique. The one thing I will say is that I was using the green glove for it. The way our gloves are, the green ones are a little bit more robust, like a green number 9. And the one time they didn't have one at a hospital I don't work as much at, part of the glove, when I distracted, sort of went flying off. So I now stick with the more robust green undergloves only, and I will not use any other glove. I don't know if you can give a recommendation on brand from your experience, but yeah, I only the green glove now.
It's funny that you said that, because I think, I've suggested a number 9 glove here, and that's at one hospital because it's got the perfect amount of elasticity where as you insert the glove, the retractor, it doesn't bunch up to the end of the retractor, and then you don't have that barrier that you really wanted. And then I'm at a different hospital and I use a number 9 glove, and guess what? It bunches up. So I've got to turn to a number 8.5 glove, and you don't really want it to be too tight, depending on how much you're opening it up, because if you do have a retractor where you can get blade deflection, it could really limit the amount of opening that you get as well. So, it's really based upon what you have available at your hospital. Experiment with it. It's going to be between an 8, 8.5, and a 9. I haven't seen anything more than that, but it'd be perfect if there was like some specific product that was designed, just to do exactly this, and it's just one single unit that we could apply, and it'd be, the same everywhere. Wouldn't you think?
Yeah, I agree. I mean, I think it's something that as this technique evolves, it'll probably come standard with kits, right? Instead of the innovators like yourself doing it sort of a MacGyver style, let's say. But yeah, I think getting some standardization, and that's going to be good. I wouldn't do a prone lateral without it now, to be honest.
Yes.
I think it's
exactly. And I when I do see that bunch up happening, I'm spending the time taking that retractor out and putting the proper size glove on there. I've been burned by visualization where it's just not good. So, you can see in this case that we were able to provide good stability for this patient. She went on to have a good outcome. Good reduction of the spondylolisthesis. You can see good height distraction and foraminal restoration. And then, she also had great restoration of the segmental angle, going from 2 degrees to 15 degrees. And when we consider prone and the benefits of the lordosis induction, we lean to the recent literature, to help guide our segmental angle goals. And we know that L4 through S1 angle is pretty stable around 35 to 40 degrees, which has really helped us to simplify our segmental angle goals. And so we're looking for an L4 fiber angle of 15 degrees to 20 degrees whenever we're doing these type of surgeries. And being that I was a open and then MIS TLIF surgeon, most of my laterals have been, most of my TLIFs have transitioned to laterals. That's really where my increase in laterals came from. And so what I wanted to do is see, well, how are we doing and how does it compare to our previous technique? We would use expandable TLIF implant for the majority of our cases, which would go to 20 degrees if we wanted to. And, you know, Mike, you've mentioned that expandables, you went through that phase and weren't really particularly impressed by it, just higher instance of subsidence at times. And I've seen that from time to time as well. And what we found is that our ability to restore segmental alignment and increase segmental alignment in prone lateral has been much better than what we've done with TLIF. And so prone lateral has significantly higher success rate of achieving our segmental angle goals, especially at L4-5. And I feel that's really from, you know, intuitively what we know, which is just a much wider release of the disc space, placing a much larger inner body that goes from the apophysis to apophysis, and also in the anterior posterior dimension as well. And those alignment, you know, those benefits from restoring segmental alignment is both for like single level cases to even multi-level cases like this. And so as we've gained experience during our learning curve, you know, we had improved retracted times, but there were times in the beginning when we were doing prone where we had to abort. And they were for various reasons. There was a time where, you know, the working distance was just too much. And what we learned is that, you know, our retractor blades are 180 millimeters, and the working distance is standard lateral. It's probably an increase of about 20 millimeters. Have you seen that too, Mike?
Yeah, agree, 100%. You have to have slightly longer blades, and there are some patients that I early in the experience just realized that we couldn't do prone on because we didn't have long enough blades.
Yeah, so that had been a nuance in which we appreciated pretty early, and there were times in which we had to navigate a high iliac crest because, you know, using our setup with the bolsters provided us some contralateral bolstering and some resistance to the forces that we were directing towards the spine, but you know, we were unable to chronally deviate the patient like you would gently when you're doing it in standard lateral. And so that brings us to our next trick. And so, you know, anytime we had an iliac crest that was extended higher into the L4 vertebra, we had some difficulty accessing the disc space. So we'd use a 90 millimeter caudal retractor blade. And the reason why we used 90 was because it still had that little extended piece of metal where we could place the anterior retractor on. And that small blade would be on the pelvic side. And that combined with the glove technique would give us, and then that fourth blade that would come in ventrally would give us that safe working corridor like you can see in figure C. And if you have a short blade on the downside, on the pelvic side, you can see in figure D that the angled instruments, you can have them work for you more effectively. They work outside of the retractor blade, so they're not hidden up against the retractor. Because if they do, what they then do is cause the retractor to pull out. So we were able to navigate high crest by using this little trick combined with the glove trick. And here's a case of a 75-year-old male. He had spondylolisthesis at L3-4. He had severe foraminal stenosis at L4-5. And we used a short blade trick. And in this case, it still wasn't good enough. His crest was so high and he was so narrow that that angle was just way too oblique. And you could see here with this angled instrument, I was unable to maneuver the cub along the inferior end plate of L4. But we're in the prone position. And so being in the prone position, you can easily audible. So we, complete our L3-4 lateral and audible to a T-lift at L4-5. And, this is not my favorite construct, putting a T-lift at the base of a two-level fusion like this. But in this case, I think it's a reasonable solution for a problem that we had. We were able to obtain our alignment goals, decompress the right foraminal stenosis by doing a direct decompression on the patient, and so he had a reasonable good outcome. So I hope that the fusion takes at L4-5. But what I'm demonstrating here is that when things don't go like you intended them to, and that happened in our early learning curve, that I bought into your plan B, which was my typical plan A, is not such a bad thing. And so, following along the journey of our learning curve, there were times in which we had inadvertent ALL rupture. And there was an X-ray like this. And so, that's not a good day, and you definitely can't keep it that way. And so that can happen. And what we found is, which is probably the most important piece about prone, is that retractor instability is a big problem, and the primary problem to address when solving for prone. And some people do it through anchoring the retractor to the disc space with two shims. I think that's a good solution. Some companies do it by placing the retractor on a robotic arm to increase stability. But we do know that retractor instability is a big problem. And there's two main methods of failure when we talk about retractor instability. There's going to be the back and forth, the medial lateral piston in effect. When you are malleting anything inside the disc space, the spine moves away from you.
Hey, Ashish. I think Ashish is back. We have a few technical issues.
Oh, yeah, here you go.
You're back.
Yeah.
Do you want to go screen share again?
Yeah.
Yeah.
You see
I
that?
think after all years, yeah, we got you back.
All right.
We got you back. I was done.
All right. Well, I don't know how long I was running my mouth for. The piston in effect, and that includes the posterior blade deflection. And so when you have this unrecognized ventral migration of the retractor, you can run into problems where you're placing your tools more ventrally and inadvertently rupture the ALL, which I did a couple of times in the beginning of my learning curve. And so our solution to that problem was that we would analyze the axial MRI to evaluate for the fat plane in front of the disc space between the ALL and the vessels. And then intra-op, we would use a carb to develop that plane. And now we place an ALL retractor every single time we do a prone lateral. And so you can see that in figure A, marked out where the ALL retractor is down there, and then on figure B in the X-ray. But figure C is inside the working corridor, and the importance of this is that you've really marked out the anterior aspect of the disc space, and you've got something between the ALL and the vessels. And so now we work from anterior to posterior, where we leave a cuff of tissue, approximately 5 to 7 millimeters of ALL tissue and anterior annulus. And then we work backwards to do our discectomy. And what that's allowed us to do is actually do more thorough discectomies. And so we're releasing the disc space much more widely, which allows us to get nice distraction, nice restoration of lordosis. But most importantly, what it does is tells us where the ALL is and avoid an inadvertent ALL rupture.
Ashish, I think that's really nice. I use it sometimes when I'm worried. Other times where I'm clearly in the right plane, I don't. So I sort of mix and match with the ALL blade. But I don't use it all the time, but certainly do sometimes. I know you broke up a bit there, but when we were talking about retractor stability, I tend to use a shim if I'm worried, and I use a single docking port. But we have a second docking port available, so we can use double arm. Do you use double arm routinely or only in larger patients? Is that something you've done, using actually 2 retractor arms?
I haven't. I think what we're doing is we're adding we're accommodating for the retractor instability in the prone position, right? And so we're trying to add anything that we can to increase stability. But the key to perform prone lateral right now, outside when we start to think about the technologies that we can introduce to make this more reliable and more reproducible, is going to be patient stability and retractor stability. And the key is going to be, how do we anchor the retractor to the spine? There's screw shims that are available that go into the cranial caudal blade currently, and what's nice about that is it does provide some stability of the retractor to the spine, but it doesn't prevent posterior blade deflection ventrally. And so you have to answer that issue. So in addition to the pistoning, you really want to prevent the posterior blade from migrating ventrally. So I haven't done the double arm. I've found probably a way, maybe because of the shim itself, to find my method to gain that stability, but I've seen a lot of people use the double arm.
Yeah.
Are you doing any bolstering?
No, I don't do double arm routinely, but for a larger patient or a difficult angle, the other time I'll do it is at the higher levels. So sometimes if you're doing a multi-level prone lateral, you start at the bottom, L4-5, you fight the crest, L3-4 is sweet. And, we can talk about that a bit later about what to start on. And then 2-3 is okay. And then you do a 1-2 and you're really fighting that rib. And that's where I find if you're fighting the ribs, having 2 arms available can be very helpful.
Yeah, no, absolutely. And so you found a way to work around that and obtain the stability that you need to do the surgery safely. And what we're trying to shoot for is trying to find a way where we can dock that retractor to the spine. So the learning curve continues, and we found a way where we can avoid the ALL rupture. And with the introduction of navigation and robotics and intraoperative spin to see where you are in space, I mean, that also adds an element of safety. So you know exactly where you are. So, primarily what I'm talking about is a fluoro-based technique. And so you can check on the fluoro to see where you are if you're nervous about retractor by placing that every time. And what that's allowed me to do is really get more comfortable with doing more complex type of laterals too, like ACRs as well. So the learning curve continues, and there were moments where we had post-operative quadricep weakness when we're first going through this learning curve. And we know that in the prone position, the hips and knees are extended. The psoas moves more posteriorly. The plexus is more taut and moves more posteriorly, as well as the nerve roots as well. So we know also that L4-5, as you start to get more comfortable doing lateral, you are doing more 4-5. And, it's not unique to the prone position. Having postoperative neuropraxia has been reported in the literature to happen and occur around somewhere between 1% to 3%. And when you add the element of prone to this and trying to stay safe within the working corridor, there's a lot of nuance to it as well. I mean, how do you test all 4 quadrants with the EMG probe with a retractor looking down like that? And so what we've done is, once we place the retractor and before we take all of the dilators out, we keep the initial dilator in, which has that EMG stim on there. And we stimulate the posterior blade, make sure that the nerve is posterior to us. So we have typically low numbers. And then we spin the initial dilator with the electrode on there to make sure that we have something favorable and safe, 50 milliamps or greater. At that point, we know the surgical corridor is safe, and we place our shim. But then there's the greater issue at large too, which is, the neuropraxia. Once you've docked, what do you do then? What are we doing to evaluate for real-time nerve health during lateral, from the time of docking to the time of implant placement? And EMGs and SSCPs are pretty standard for lateral, but the issue is that they have low sensitivity or low specificity for detecting a postoperative neuropraxia. And so most surgeons use the time in the psoas as a surrogate for potential nerve injury. And for me, that's not really scientific at all. There's a modality that's been around called TMAP, or transabdominal muscle action potential, and it's a stimulation of the proximal end of the cauda equina and elicits a depolarization down the nerve roots through the lumbosacral pathway. And the electrodes in the myotomes in the lower extremities pick up that response. And it really allows for the evaluation of nerve integrity in real time. So much like you run a motor during deformity surgery, especially during screw placement or the critical parts of deformity correction, that's what I use TMAP for when I'm performing my lateral. I had a case where, everything went pretty smooth. The EMG was nice. I docked in a good place. I performed the lateral, and 2-level L3-4 and L4-5, and postoperatively, the patient shows weakness in the recovery room. And I looked at the steps that I had, and I was like, when could that have possibly happened? Maybe our retracted time being like 25 or 30 minutes. Is it towards the end of that? Is the 20-minute threshold like a real criteria? And when you take a look at all the steps on lateral surgery, from dilator placement to retractor placement, shim placement, opening the retractor initially, opening it maximally, discectomy and cage placement, you could have an injury at any one of those moments. And so what we've done is we've devised a protocol in which we run TMAP, the critical steps of the lateral approach. And that gives us, a event-based understanding of what's happening with the nerve. Here's a case example of a patient, L4 through S1 disease, and planned for L4-5 prone lateral. I placed the dilator. EMG showed I was in a safe spot. I placed the rest of the dilators in the retractor, opened it initially, and ran my TMAP as I usually do, and I lost my signals on the approach side in the vastus lateralis and the medial. So you can see what that read looks like on the TMAP screen. So I closed my retractor down and waited a minute, waited two, ran it again. Signals were still gone. You can see kind of a flat line where those signals are.
I think I've lost Ashish there for a moment. If anyone's got any questions, fire them into the chat box. We've just lost his connection there for a moment. But I do not use this TMAP, but I saw Ashish talking about it on LinkedIn, and I thought this is a really potentially helpful thing, because with all these techniques, we just really want to avoid nerve injury. We'll get him back on in a sec. These are procedures where I think the microscope is still on us as surgeons when we take these things on, particularly if you want to start doing this, in a center which hasn't done a lot of this type of surgery before. While Ashish gets back on, what I'm going to do is just a quick talk about, from my perspective, about taking this on, right? And I don't know how many people on here are lateral surgeons or interested in lateral surgery. I see David Yam is on the meeting, which is great. Simon Clark's here as well. Simon's mentioned that the TMAP seems a step forward. Seems sensible to use it. And yeah, I kind of agree. And I think we're in an era where we've got to be increasingly watching our back on the complications and things going wrong, and no one likes it. And I think we've got to use these technologies to our advantage. And so my recommendation, if you're going to take on prone lateral, as someone who did it without the ability of doing visitations and other things because of COVID, is that if you're a good lateral surgeon, you've done 25 plus lateral cages, then, and you're doing them fairly regularly, then you'll probably be able to certainly do L3-4 in a prone lateral. And that would be the level to start at, much like when you start regular lateral surgery. And then if you do L3-4 and you're doing that well, and patient doesn't have low-lying ribs, then go up to 2-3. And then you find your perfect patient after about 15 to 20 cages to do 4-5. And so that would be the order that I learned it in, and I would do it all from the left side to start with. And as you get better at it, you can actually start to do it from other sides, contralateral side, much like you do with regular lateral surgery. One of the things that I really big advantage for this technique, and I'm sure Ashish is going to talk about it, but what I love about this is that in the prone position, you can have your screws in the back. You can do a facetectomy. You can even do a whole ponte osteotomy if you're doing an open, or if you do an MIS, you could do a facetectomy. And after your cage goes in, you can literally lean on the spine to try to recreate lordosis as you put your cage in. And for that reason, Ashish and I will differ a bit on this, but I use expandable cages for this. And the expandables are very helpful to me, because what you can do with an expandable cage, it's implanted, you can sort of lean on the back, you can even start to drop rods and reduce using the mechanical power of your implants rather than physical force. Oop, Ashish is back. Excellent. We'll get him back in. But you can actually get further lordosis as you expand the cage, so as you wind it up. So we'll I've got a case I can show just while Ashish is doing that. I'll see if I can share my screen and just show the case that we're able to do with that. Oh, wait up. I'll unmute you.
Beaut, thank you. Don't you love that? Getting knocked right back and forth like that.
It's okay, Ashish. I'm able to talk. I'm able to talk in a vacuum, mate. So we're okay. We were just having a just saying that we differ a bit on expanded, which we'll talk about later. But you were up to just the TMAP and loss of signals in your case when I lost you.
Yes. All right. Do you see that again then?
Yeah, you're on your preliminary study now. Beautiful.
Yeah. So you know what I did? I mean, but just because we have to be more sophisticated with our approach in the OR around like nerve integrity, you know, we ran TMAP in off and SSCP and then compared it to retracted time. And what we did was we correlated that with our post-operative exam in the patient while they're doing their physiotherapy while they're in the hospital. And because there's nuance around what weakness is, you know, you can have poor effort, you can have pain, you can have a 4 out of 5 hip flexor, you can have maybe like a 4 out of 5 quad. We defined an issue as 3 out of 5 or knee buckling during the postoperative phase, right? And so what we found was that retracted time really had a very low sensitivity and specificity for for catching an injury. I mean, there are often times where we can have retracted times 20 minutes, 15 minutes. You know, some people get really good and they're at 10 minutes. SSCP performed just a little bit better than that, but you know, we've got to define posterior tibial SSCPs or saphenous SSCPs. I think saphenous SSCPs have more promise, being the distal end of the femoral nerve. There's some difficulties with obtaining it every time. You know, I think our neuromonitoring techs feel like the saphenous nerve is a little finicky to get reliably, being deeper and smaller bore and stuff. But what we found was that TMAP and using this protocol in which we ran it in the most critical steps of lateral had a sensitivity of 100% and a specificity greater than 90% of capturing a post-operative clinical weakness. And that could be in the moment where you may have a weakness and you may have a weakness regardless, but there could be a moment in which you're having to develop or evolve an issue that can allow you to change or maneuver intraoperatively. And that's either saving the patient from having an injury or reducing the time that the injury is happening. And being in the prone position is special because you can audible, you can change your surgical plan. And we had no false negatives, which, you know, when you're thinking about trust in system or modality, that's critical, because the worst thing is where everything looks fine and then post-operatively you have an issue. I mean, as with deformity surgery, we lean so heavily on motors to understand whether our correction is going to be safe or not. And so we need that same level of trust and reproducibility with a modality in the lateral space. And so I've made a video, and you can see the QR code in which we explain our approach to TMAP. So the learning curve continues, and you know, as we've become comfortable, we're like, all right, well, look, we've found a way to increase our visualization during the surgical corridor. And when we abort, we've got a great plan B. We're trying to stay safe and monitor nerve health, and we place the ALL retractor to prevent any sort of inadvertent injuries of the ALL or the vessels. And now we're working on ergonomics. You know, looking down the barrel of the retractor in the prone position when it's perfectly orthogonal is uncomfortable. And we want to make surgery comfortable. And so you can see that either I've got neck hyperextension on the left, or my neck is cocked to the right or left when looking down the corridor in that fashion. And so we started rotating the bed. And we sit when we perform the discectomy part. I stand when I'm doing the approach into the retroperitoneum. Once I'm docked, I sit down. And just very mild rotation of the bed, 5 to 10 degrees away, creates more of a neutral neck position. But does this affect where we place our implant? Because we want to get that right every single time. And so if you place the retractor in the perfectly orthogonal position, AP X-ray shows, a perfect AP, pedicles are symmetric and spinous process midline, and have the retractor handle standing upright, well, that becomes your new reference as you rotate the table away. And so our margin of error as we became comfortable with prone lateral procedure was around 3 degrees, which is very, very acceptable. So, as we've become better at performing the prone lateral, especially in the degenerative disease, we've learned the critical pieces that are going to bring us that 2.0 version of prone. And it really basically boils down to 2 pieces. It's going to be patient stability, and that's done through patient positioners, and there are some on the market. ATEC has one, Globus has one, Invasive are going to launch one that moves in the sagittal plane as well. And so that'd be amazing to see, so that you can actually influence the sagittal angle. And then it's going to be retractor stability. How do you anchor to the spine? And we've developed a screw shim that goes down the posterior blade, and the posterior blade is preferred over the craniocaudal blades. Just depends where your craniocaudal blades are. Here you can see that they're pretty anterior, and so placing a screw shim down there, well, may not be ideal. But the other thing is that it also prevents the posterior blade from deflecting ventrally. And at this video, you can see the bed is slightly rotated. I've placed my implant into L4-5. I'm taking out my ALL retractor. I'm undoing the articulating arm, which I have for stability as well. And as I loosen these things, I have that screw shim in there in the posterior blade. And what I'm demonstrating is how stable the retractor is to the spine with just the screw shim alone. And so that's the type of stability that we need. We need to have that stability so that we can improve our reproducibility of this technique. So I've kind of described the learning curve. Yeah.
Oh, she's got a question on the text on the chat box from Daniel. Just basically saying, well, statement first, recent paper highlighted saphenous nerve stimulation was better, and that's what you were saying as well. So it's been backed up recent literature, but then also asking about your ruptured ALL case, and did they have complications? And I suppose my question is, how did you salvage it? Were you able to get a lateral cage back in, or did you have to abort and do TLIF or ALIF, or what happened?
Yeah. So, when you have an ALL rupture and the implant looks that far anterior, like, the concern is obviously vessel injury. And thankfully, I never had a vessel injury. And when I place that ALL retractor now, every time, what I'm doing is I'm placing a barrier between the ALL and the vessels. And so, one, I've avoided having further ALL ruptures, right? But what you realize is that when you do have an ALL rupture and the implant looks that far anterior, you've got to restart what you do. There's a reason why it's getting pushed out anteriorly. One, it doesn't have that barrier anymore. But just like if you perform an inadvertent ALL resection or an actual intended ALL resection, you've got to go as far posteriorly as you can. If the nerve is allowing you in the EMG stim are favorable and you can march backwards in the disc space and redock and take out more posterior disc, you can then force the implant posteriorly and then orthogonalize so that the implant is as posterior as you can place it. There is another technique, being in prone position, you can place your screws, you can perform a reduction, or you can manipulate the disc space or close down the disc space. And so that's another element in which, if the ALL is ruptured, you can kind of salvage that situation. Obviously, worse comes to worse and you're not you're not able to place an implant because it just keeps spinning out anteriorly, don't put one in there. You know, go to the posterior lateral space, burr it out, place some bone graft, place some screws.
I think the good thing about prone lateral, though, is that you've usually got your screws in the back or you're ready to do them. You know, this can happen with a regular lateral sometimes to people as well. And unless you've got like an anchor ready to go, like a combined integrated cage, you know, it's almost impossible to hold it in there. And so, yeah, I think having the posterior screws in and ready to drop rod, you know, you can come back at a later date and do something else if you have to as well. You can give you stability from the back temporarily. So that's a good thing about the prone technique in some ways.
Yeah, it's very versatile, right? Like you can go back and forth, and like the next case, like the case that I was going to show, just really demonstrates that versatility. And personally, I mean, you have a revision type practice, and so do I, and so that versatility is like it's really nice. But yeah, your comment around placing the lateral plate, once you do have the implant in a good position, you do want to fix it there if you can. And so, you know, what we're showing is that, you know, the learning curve occurs, and as you gain more experience, you know, you're going to have some challenges in the beginning. And it took us about 30 cases before we really became comfortable with this technique. For some people who have more lateral experience, I think that learning curve is much shorter. And for those that don't, I mean, it could be a little bit longer. But what we're trying to do is develop some tools to improve the reproducibility of this approach for the masses. And the reason why I wanted to talk through this learning curve specifically is that this is a global audience. Not everybody has access to the newest tech, and there are companies that are doing a good job of creating those solutions specific for prone. And I think that most other companies are going to follow suit in that way. I think it's just a really interesting and versatile approach as we get into trying to find surgical efficiency and perform what we're trying to do, which is good surgery, A lifts, L lifts, in a more efficient manner. And so, you know, we can see that with the prone positioning, like what we talk through is the placement of the lateral interbody, but being in the prone position, you have access to laminectomy, osteotomies. We talk through TMAP and how I try to stay safe or at least evaluate real-time nerve data. And, you know, I want to get back to the case that we presented earlier, which was that 48-year-old female. And so, you know, I think we all realize that there needs to be some sort of osteotomy that's conducted in the distal lumbar spine, right? And that L23 disc, I mean, it's almost on its way out. Probably needs to be addressed, but, you know, everything else above that looks pretty reasonable. And so we planned an S1 PSO. We know chasing a pelvic instance of 100 degrees is futile. And so we had to adjust that. And I bumped into Chris Ames like a week before doing the surgery, and he gave me his tips on how to stay safe and what to do. And I really valued that. And so we created that wedge osteotomy and removed that L5-S1 T-lift, which wasn't fun. That was really sucked in there. Closed down the osteotomy. And, you know, once the ostomy was closed down and we looked at our intraop films, it was like, yeah, it looks really good, but that L23 disc, you know, it still looked hyperlordotic. It needed to be addressed. And we wanted to address that by placing a hyperlordotic implant. And so the nice thing about this is that, like, objective number one was a large osteotomy to correct or to restore the PI to a more reasonable number. But you can go back into the flank and perform a prone lateral as a secondary step without changing the patient's position. And we placed a 20-degree hyperlordotic implant in there. You can see the tab in there in case we needed a fix to the spine. In this case, the ALL there was still a barrier there, so we didn't really need to put a screw in it. And these are the intra-op films, and here you can see the post-operative films. And what we were able to do was reduce the pelvic instance by 30 degrees. We were able to reduce the sacral slope. That was near vertical at 90 degrees. And so that's more reasonable at 52. And actually lordosis itself compensated by decreasing to about 20 by 24 degrees. You can see from pre-op to 2 weeks, and we saw her again actually today for her 1 year post-op, and you can see the alignment's maintained, and it actually looks really good.
That looks really good, Ashish. I mean, that's a great result for her.
Great result for her. I mean, she did have a lot of paresthesias in the S1 dermatome and bilateral feet, which improved on the left side, and she's still dealing with on the right side. So these kind of cases aren't without their issues, but no foot drop. Got fortunate there, and just really good alignment. So she's very pleased about that.
Does her cord stim help with her paresthesias at all? I mean,
it did.
But you know,
it actually did, yeah. I mean, she enough where we knew, like, post-operatively she had a remote control for her cord stim, and it went missing for about a week, and she was dealing with it. And as soon as she found the remote control and applied it, she said it helped about 50%.
There you go. Yeah. That's why sometimes it's valuable to come in, right? I mean, a lot of spine surgeons look at these things and just go, they're horrible, get it out of there, get it out of there. But I think if it's an MRI compatible one and you're not operating directly in the area, you know, it can be occasionally good to leave it in.
Oh yeah, for sure. And my bias is to leave it in if I can. And the patients sometimes request it too. They just, especially if it's been working for them, they want to keep it.
Yeah. Rodrigo Amaro's just mentioned it's a beautiful case. So yeah, I think most of us would agree with that.
Yeah, and really the case kind of highlights, I mean, we were talking through the learning curve and degenerative disease, and that's really the main application when you consider prone. Like when you consider deformity surgery or multi-level surgery, you've got to do what feels comfortable for you. And if you're doing a 3-level, like the time it takes for you to do a 3-level, when you consider the flip, for some people, the flip is 15 minutes. For some people, the flip is an hour. And so, you know, when you consider a 3-level, the percentage of time savings is reduced. But when you talk about 1-level surgery, single position surgery, whether it's a lateral position or in the prone position, really makes a lot of sense for that 1-level degen case. Here, the versatility, here the versatility is like you can mix and match and add it to deformity surgery as well. And even if you think of it at a later stage, or say if things are going well, I'm going to add it. That's a really nice thing to do. Here's a case of a 70-year-old, in fact, and you can see that she's kind of PJK'd above her previous fusion, which was also flat from L2 through L5. It's kind of weird, actually, finding she just has absolute bone loss. 5, 4, 3, 2, 1 at L1, just like a vacuum there. When she lays down recumbently on the MRI or the CT scan, there's just bone is completely missing. And as she stands, you can see on the previous picture, I mean, it just flexes forward. So she was unable to stand. She was unable to walk. 3 months prior to her presentation, she was just completely fine. So hard to know exactly why this happened. She's rheumatoid arthritis. L5S1 disc space is completely collapsed. And so, you know, our comfort with prone and degenerative cases translated to our ability to do more complex cases. And so, you know, a tip is whenever you're doing a prone ACR or a prone corpectomy, you know, translatory forces are heightened, right? So the patient is on the Jackson. There's no actual, there's nothing to prevent them from translating once you start to take bone away. And so we like to put our screws in first. Here you can see a case where I've got 1 screw above and 1 below, but preferably as you're in the mid to distal lumbar spine, you've got, or somebody who's heavier like the last patient, you want to go 2 screws above and 2 screws below and a temporary rod. And as you're doing your bone work, that the screws can hold some stability, especially to prevent translation. And then as you place your implant, you want to loosen the set caps so that you can get the expansion of the corpectomy implant. We addressed L5S1 in this case. We placed the corpectomy to fill the void, and then we extended her up to T10, and she was doing pretty good, regained the ability to ambulate, you know, and doing quite well. Have you used the prone technique, Mike? Doing it
not for a corpectomy. I haven't been brave enough to do a corpectomy yet with it, but I think I could. I just haven't come across the right case. But I have seen similar pathology in rheumatoids.
Yes.
With you know, this happens in rheumatoid patients. They'll do fine after a fusion for years, and they'll just get this rapid deterioration, and it's almost like a Charcot joint in spinal cord injury. It's often not infected, but it's like just a complete collapse. So yeah, I've seen it. I've used very large expandable cages to fill similar defects, but not haven't had to do a complete corpectomy yet. But I'll be having a look at your video before I do my first, I think.
Yeah. Well, what we got a good result, and I think the critical piece around this when we're talking about tips and tricks is make sure that you put a temporary rod in, especially if you're creating like a 3-column, you know, like either through a corpectomy or an ACR.
Yeah.
A case of just a thoracolumbar curve in the patient who had trunk shift. And the nice thing is, like, now as we start to think through our T10 to the pelvis and deformity corrections, we can apply you know, lateral cages and combine them with Smith-Peterson osteotomies to try to either increase coronal correction, sagittal correction, or even for fusion itself. And then lastly, you know, a patient who has both coronal and sagittal malalignment and a failed previous L4 through S1 fusion. And in this case, unfortunately, it fused because of the BMP in this position. And, you know, we try to avoid a PSO when we can. And I think the highest level that I'll do a ACR in is like a L3-4. I'm not trying to shift the apex of the lordosis too high, if I can help it. Here we performed an asymmetric ACR, again, placing a temporary rod. After we perform the ACR, we go into the posterior space and perform a Smith-Peterson osteotomy and make sure, just like a PSO, we have a temporary rod in place. And reasonable alignment, didn't get her corrected coronally all the way, but reasonable for her age and, you know, her function, by, again, combining lateral surgery with posterior base surgery. Well, thank you, Mike, and thank you for having me and hosting me.
Ashish, thank you. I think this will go up on YouTube later, and then hopefully you can link your videos, which are fantastic, and I've seen before, to the talk. We may be able to do that. I got another question from Rodrigo. How often do you have to use ACRs in the prone position? I suppose, yeah, Ashish, how many sort of true ACRs have you done in your series, do you reckon?
I think it's less than 10. So we're talking about maybe 8 or 9. And I think to Rodrigo's point, what we're finding is that in the prone position, we're able to place these 20, like just like the S1 PSO case, that 20-degree implant, and we achieved all 20, was placed without sectioning the ALL. So there was still an ALL. I mean, we're using disc-space distraction to allow us to stretch out the fibers of the ALL, and you have to keep the anterior annulus out. But what we find is that you can put these hyperlordotic implants, these 20-degree implants in, and get it all 20 degrees without actually cutting through the ALL. When I perform an ACR, I'm trying to get 30. So that means I'm placing a 30-degree implant with the smallest posterior height, and then I do a Smith-Pete in the back and I close it down. So that's the only time that I'm actually doing a formal ACR. Otherwise, the 20-degree implants actually go in more often than you think.
Rodrigo, if you want to ask a follow-up, I can unmute you. Good. All right. I look, and I mean, I think that's where, I teach my fellows to do this technique, and I use the reversed angled curette to feel under II, but also you can feel the ALL with that as you come to the front, and you can actually like just sort of take that through a little bit to loosen it off the bone at the front of the disc. It's quite a safe way of doing things rather than going there with a sharp instrument. Is just use this reverse angled curette across the front of the ALL. I suppose we are at the just over the hour. I know we had a few minor tech issues, so we kept it going for sure. But the one thing I will say is that now that the world is open again and we can all do some traveling, I reckon it's a good idea if you want to take on prone lateral to go and visit people that are good at doing it. And you should try to take your company people and even your nursing team with you, because there's a lot of setup in theater. Ashish, would you agree? Like there's a lot of little points on setup where you put your clamps and everything that you need to work on to do this, right? And I think, if you have a visitation, like just hit Ashish on LinkedIn and just go, how can I visit, right?
Yeah, it's true. I mean, there's a lot of nuance and a lot of work that we've done that you guys don't have to figure out, right? And that's Rodrigo is a master at doing the prone position as well. I mean, I think people that start to explore that space and deliberately and safely really enjoy surgery, and not just the surgeon, the reps, the nursing staff, your PAs, everybody starts to say, I don't want to flip anymore. I don't want to bring the table in and bring the table out. And before you know it, everybody's chirping like, hey, Patel doesn't flip. And they're talking to the other guys who're still flipping, like, why are you still flipping? So I don't know. It definitely creates a buzz, but I agree with you. The point is to do it safely. I mean, I wanted to share my mistakes, and that's kind of the reason for the educational tools and the educational videos, is try to explain all the things that we've seen and that you may see if you came to visit before you come to visit. But if you do come to visit, I think we'll show you a good time, and we'll make sure that you've got all the most main points down before you leave.
Yeah, I think that's the important thing, is having a bit of a mentor and working your way through it, because the mistakes are there, and you've made them, I've made them, I'm sure Rodrigo and John have made them as well. So, but if we can pass that knowledge on, it's always a good thing. Ashish, thank you so much. I love the talk. It's just awesome. We like the interactivity of this and the honesty and presentation and how you work through it. But I really think that this technique is it isn't a fad, it's sticking around. And I think, for a lot of the reasons you said, we just got to keep moving and keep going forward with it. So thank you very much. Thanks to those who joined us. Thanks to the whole audience. A few thank yous coming through. If it's popular, we can certainly run this again, because there may be other aspects of this we need to talk about as well.
Yeah, I could spend an hour on the neuromonitoring thing, but I mean,
well, that may be something we have to do. As I said, always feel free to hit us up on LinkedIn or Twitter. I think next week for Virtual Spine, a wonderful radiologist, Wendy Gibbs, is on. I'm not sure what the topic is yet, but we'll advertise it on LinkedIn and Twitter and go from there. But thank you very much again, Ashish, Rodrigo, Alexander, everyone that joined us, right? And we'll see you all next week. Thank you.
Thank you, guys. Take care.